Good afternoon and welcome to our webinar, What are skill mix innovations in the health workforce and what do we know of their effects? Over the last couple of weeks, we have discussed a couple of very serious health workforce issues. We've been talking about the looming crisis in Europe, but also elsewhere globally. We've been talking about the shortages, the failure of retention of health workers. We've been talking about medical deserts, the undersupply in remote and rural areas. And these are all very important and pressing issues. But one thing we must not forget, that the foundational issue actually is to better align the health workforce to the models of care we want to push forward. And this is in particular primary care and integrated care. And skill mix reforms provide an important answer to these pressing questions. And we hope that these skill mix reforms increase the performance of health systems and make better use of our scarce resources and in particular of health workers. And today's webinar is based on a lot of publication, actually a major volume our keynote speaker will talk about, but there are also policy briefs and scientific articles. Only this week, actually, a new article on skill mix and health promotion and prevention came out. Today, we are very happy to have as our keynote speaker, Claudia Maier from the Technical University of Berlin. Claudia was leading our skill mix project, and she's continuing to work on the topic actually and publishing a lot of papers on this. And as spotlight speakers, we have today Johanna Heikkilä from the University of Applied Science in Finland. And she's not only a nurse trainer, a curricula developer. She's not only active in Finland, but she's also been active, especially in Kazakhstan and other places in Central Asia. And in addition, I'm very happy to welcome my colleague Juliane Winkelmann from the Observatory, who will also talk about skill mix innovation in primary and chronic care. So just before we start, a couple of things on the housekeeping. Please use your chat, put all your questions, comments, ideas, or even if you have a publication, you can put it into the chat. And towards the end of the webinar, we will have a panel discussion and my colleague Erika will feed these questions back to the panelists so that you get some answers to this. We will also record this session and the session's video will be available on our YouTube channel in a couple of days. So that's about it. And I would say, Erika, please start the participant poll.
And we wanted to know, are health workforce and skill mix changes high on the policy agenda in your country? That's a straightforward yes/no question. But then also we wanted to know a little bit more details. So are any skill mix changes in the health workforce being implemented around advanced roles for nurses, advanced roles for pharmacists, multi-professional teams in primary care, patient navigators for patients with chronic conditions or multimorbidity, peer educators in mental health, lay educators in health promotion and prevention, support for informal carers providing long-term or even palliative care, or indeed none of the above. So please do share the experiences from your countries. Thank you very much. Back to you in the studio.
Thank you so much, Erika, for this. And from the poll question, you can see that skill mix reforms are not only directed to the health professions as such, like nurses, pharmacists, and others, but also to patients and lay people. And we are quite curious to hear about this and how they can actually contribute to improved skill mix in primary and chronic care. So that's the moment that I give the floor to Claudia Maier. Claudia, please start with your presentation.
Yes, hello. Good morning, good afternoon to everyone. Thank you for being here. It's a great pleasure for me to give you an insight into, I would say, the largest study that we did on skill mix changes and skill mix innovation. I'm going to give you an insight into the study, and the focus was on skill mix innovations, what is out there, what do we know about the effectiveness, and lessons for implementation. And here you can see the book. The book has been published last year. It's available open access online, and I'm sure colleagues will put the link into the chat box so you can see and read through it. And you will see it's a rich resource. So please feel free to use it, of course. What have we covered in that book? First of all, we are providing you an overview of what do we know, what is actually skill mix and why is it relevant. And then we go into the details. And here we look at what have been some of the skill mix changes and skill mix innovations. And we have divided these into 5 key areas that are relevant in primary care and ambulatory care. First of all, in the field of health promotion and prevention. Second, in acute care. Third, with regard to chronic conditions and multimorbidity. Then we look at long-term care and palliative care. And finally, access to services. And here we have covered rural areas and underserved areas, as well as in general access to services more broadly. And then we are looking at what do we know about lessons for implementation. Skill mix changes really affect health professionals, teams, but also we are taking a much broader view. We are looking at a systems perspective in terms of implementing these large-scale skill mix reforms. So what is actually skill mix? There are a wide number of different definitions. What we used for the book was skill mix changes are all changes or interventions that actually directly are targeting the skills, roles, tasks within and across individual health professions and or teams. So we are really looking at changes to the roles and skills and tasks in clinical practice. And we are looking at individual health professions, but also teamwork. And so that is about skill mix. Then second, the question is, because we are talking about skill mix innovations. And here we are using 3 criteria. First of all, an innovation. A skill mix innovation is one that is novel. So it's a new element. It's disruptive, it's changing the status quo. And thirdly, it's aimed at improving outcomes. So here the focus is on it's aimed at improving outcomes. And with our study, we are actually looking into what do we know from the evidence. Is it really showing that there have been improvements in terms of outcomes? And we're going into that in a second. So the methods, I will be very brief on the methods, but just to say it, first, one element of the methods was an overview of reviews, an overview of systematic reviews. And we went through all the literature. We used a predefined protocol, which you can see on the right-hand side, on the upper right-hand side. So have a look at that. And it was done by a core team of researchers. Here we were really looking into the effectiveness. What do we know in terms of outcomes? And then secondly, we also wanted to know, what do we know, what have been country reforms on skill mix? And here we have used case studies and other policy relevant material. Here, this is the flow chart of the overview of systematic reviews. And when we started the study, we said, well, there's probably not that much evidence out there on skill mix, but actually we were really proven wrong. So we identified a large number of systematic reviews, and you can see them here. So a total of 186 reviews were included in the book, and 171 focused on one of the 5 key areas that I just mentioned. So on health promotion, prevention, and so on. And here you can see them, they have been broken down by these 5 key areas and by issues relevant to implementation. So the largest number of systematic reviews we identified on skill mix and chronic conditions. And that's perhaps not surprisingly, because treating chronic conditions is one of the major policy relevant issues out there. And there has also been a lot of research on that. Then that was followed by health promotion and some of the other areas you can see yourself. In terms of lessons for implementations, we found actually slightly less evidence there, and you can see that here in red. So what are some of the findings? We identified several skill mix typologies, and I will show them to you in a minute. And they all, of course, relate to the team in which they work. So first of all, one of the skill mix innovations are related to a new division of work. And here we identified expanded roles and advanced practice providers. That's a very common skill mix change. The second one is outreach. So health professionals no longer working in their practice or in their setting, but actually reaching out to individuals, to patients, to communities. Third, skills to empower patients and peers. And Juliane will talk about that in the spotlight later on. Fourth, coordinator roles. And finally, skill mix changes that are directly targeted at collaboration and shared care. What have been the professions involved in these skill mix changes? We found that most of the evidence and most of the studies focus actually on nurses and pharmacists being involved in expanded roles. There were also other professions that were covered, for instance, dietitians, physical therapists, community health workers, or other lay workers. But the by far largest number was really on nurses and pharmacists. On physicians, there was less evidence, which I was a little bit surprised by. On multi-professional teams, we found quite a number of studies, but very often there was very little information about the composition of the teams and how they work together, which is one of the limitations. And then there were a large number of reviews that subsumed various professions. So we're now going into some of the findings related to patients with chronic conditions. And here you see that I mentioned nurses and pharmacists were the professions where we found the most evidence. And here we found that nurse-led care proved to be either equal or improved outcomes for patients with chronic conditions. And here you can see this was mostly shown for patients with diabetes, for patients with cardiovascular diseases, and for patients with mental health issues. And we have now here, in terms of patients' outcome, there was quite good evidence showing that it can improve at least one of the outcomes measured. In terms of resource use, there was some evidence suggesting that this may be related to an improvement in resource use. So, for instance, inpatient costs were reduced, hospitalizations were reduced, but it was less consistent than for patient outcomes. And in terms of professional outcomes, the evidence was more mixed. There was also good evidence that pharmacist-led care can improve outcomes for patients with chronic conditions, and that was mostly found for pharmacists being involved in health screenings in the pharmacy, providing immunizations, or monitoring drug interactions and medication adherence. So this was just giving you a very brief flavor of what we found in terms of skill mix changes and patients with chronic conditions. I will now move into skill mix and health promotion and prevention. And here we also found quite a number of studies showing that skill mix changes aimed at improving diet and nutrition, so really aimed at lifestyle changes, can actually improve outcomes. So here it showed that the BMI scores were significantly reduced, and BMI set scores, BMI set is for children, and it showed that it can improve fruit and vegetable consumption, among other outcomes. And the number of countries that were covered is quite a large number of countries, mostly from within Europe or high-income countries. Second, skill mix changes aimed at improving and stimulating physical activity. Here, these roles and tasks were provided by exercise or physical activity specialists or nurses or physiotherapists, and they provided tasks really aimed and targeted at improving physical activity, for instance, advice, counseling, vouchers, or referrals. And this also showed or suggested that this can improve physical activity at least for the short or medium term, so here measured at 12 months, and can have other positive effects. But it also, there was one study that showed it can also result in increased falls or injuries, because sedentary adults, of course, there is a chance that this can increase potentially negative effects as well. And here the number of countries covered was also, say, 6 to 8. So then skill mix in the field of maternal and child health. Here we have seen that this was mostly provided by nurses and midwives, which naturally also makes sense, because they are very often the first contact point for newborns and mothers with children. And the tasks here were mostly home visits or case manager role, so going to the homes of families and women with children. And there were also several outcomes that suggested that this can improve either children-specific outcomes or breastfeeding or improve parenting knowledge. Going into disease prevention, there a large number of countries have started or have implemented so-called patient navigator roles. And I am not going to say much about that, because I think this will also be covered later on by Juliane Winkelmann. But we also have seen that this may actually show and may improve outcomes in terms of screenings, particularly for vulnerable populations. Home visits is another role that we identified. And here again, their focus was on disadvantaged groups, and there have been a number of outcomes related to screenings as well, which have shown to increase. But this was based only on one country, the United States. And then the final skill mix typology, I say here, was nurse-delivered cancer screenings. Here we found some evidence on nurses taking up these cancer screenings, for instance, nurse practitioners or advanced practice nurses. And it showed that safety and effectiveness can be improved if they are adequately trained, based on 3 countries. We have just published, and Matthias mentioned that already, an article which directly looks at skill mix changes and health promotion and prevention. So if you are interested in that topic, please look it up. It was published this week. I'm not actually sure if it's already, no, it is available. Yeah, so we can send you the link later on as well. So strengths and limitations of the study. Strength is clearly, I think it's one of the largest study actually ever on skill mix changes and effectiveness. It has a broad scope. We covered all health professionals plus lay workers as well. We tried to cover really all outcome measures that are relevant. And the evidence, we had a number of Cochrane reviews and meta-analysis, which are also covered. Limitations, the book is based on reviews that were covered from 2010 to 2018. So the search was done in 2018. On health promotion and prevention, we have updated the search, and this is based on the paper I just mentioned. Then a second limitation is that the comparison group usual care was not always very clearly described. So we don't always know what is actually usual care, which of course is critical to compare the intervention with. There was sometimes limited information on the exact roles, skills and tasks that were performed. And several reviews covered a mix of professions. And then it's of course impossible to say if this now is related to the education of the profession, if the varies are subsumed. Conclusions. So there have been a multitude of skill mix changes and skill mix innovations that we have identified across countries. A lot is going on. There's a lot of evidence out there, but also in terms of country reforms, a lot is really happening. I've not touched upon that here, but you can see it in the book yourself. Country context is really important. And the question here is which roles, which professions with which education pre-exist, and where can we see the changes happening? What are the patient population needs? Of course, is also critical. The right skill level is important, and here education comes in as well. And integrating these skill mix changes into health systems. Often skill mix changes, innovations, they have been piloted, they have started in small regions, but bringing them to scale is really very often an issue, and that requires the system approach to it. And then finally, once these changes have been taken up, recruiting and retaining the health professionals is really key. So with that, I want to conclude and say thank you very much. I'm here for the next 45 minutes and very happy to be further involved. Thank you.
Claudia, thank you so much for this fantastic overview on this huge study. And of course, it was an overview, and then you zoomed in into health promotion. But just for all for the audience, the study covers actually all settings of primary care and chronic care, and even transitional care to the hospital sector, but it excludes the hospital sector as such. But it's, of course, the biggest and most comprehensive study on this. And it's also great to see that you are updating some of these parts, and health promotion is certainly part of it. And you know what I found encouraging, Claudia, that for quite a number of the segments you looked into, in health promotion and prevention, there was a diverse set of countries, where the positive evidence was coming forward. That gives me the feeling it can be possible, the argument, no, not in my country doesn't count. It is possible to implement this successfully. And we will hear some of these success stories actually in the following presentations. But before we go to Johanna from Finland, I would like to ask my colleague Erika to present the results of the poll.
Hello, everyone. Yes. So I was quite surprised by the response to the first question, where sort of 2 in 5 of you were saying that the health workforce and skill mix changes are not currently high on the policy agenda in your country. So I found that quite surprising, but perhaps less surprising in view of the research done by Claudia and her team. The big skill mix changes being implemented are around advanced roles for nurses, multi-professional teams in primary care, and advanced roles for pharmacists, with the others coming sort of further down. But I think those will change as time goes on. So thank you very much for your feedback on that. If you have
very interesting results,
put them in the chat box.
Very interesting results, Erika, and of course, on one hand, very promising, so that almost 60% of colleagues in the audience have some experience in their country with skill mix reforms, and I think that is actually happening, and the nurses and prescribing roles are more widespread now than they were a couple of years ago. What I also find quite interesting is the multi-professional teams in primary care. We haven't had much time to talk about them, but I think that is quite crucial, and probably, at least in the panel discussion, we will have a little bit of an insight on this one. But now I'm super curious to hear from Johanna the Finnish experience. And as I introduced you, Johanna, you're not only a nurse researcher, a curricula developer, you're also a trainer, and you are in close contact with plenty of nurse leaders in Europe and the world. And actually, Johanna was part of the team of our summer school like 4 years ago in Veneto on skill mix reforms, actually. Johanna, the floor is all yours.
Okay, so about the nurse prescribing and the multidisciplinary teams in primary healthcare. So in Finland, the nurse prescribing was introduced 10 years ago. The legal changes were done. And then we have a national network which has created a national curriculum. So all the nurse prescribers in different universities are trained by the same curriculum. So at this moment, we've trained a bit over 800 nurse prescribers. The training takes 1 year. It's part-time. And what is the situation? So practicing nurses with the rights, there are 710. Everyone is authorized, so there is a register of nurse prescribers, so we know exactly who they are. The nurse prescribers in Finland were developed to help the access to services, especially in the rural areas. So what was decided that the medications are, so they were for acute infections. So nurses can independently prescribe for urinary tract infection, pharyngitis, mastitis, and conjunctivitis. So there are these acute conditions. And then the other role which was thought for nurses was to continue medication for chronic diseases. So there is type 2 diabetes, asthma, there is hypertension, arterial fibrillation, dyslipidemia, and asthma. And then also nurses can start and continue contraceptives as well as prescribe vaccinations. So with this role, you can see in the chart in the figure left that the nurse prescriber amount is at the moment 519. However, it tells you that 25% of the nurses are not prescribing. So their role in the skill mix is not used full or annually they are not doing that work anymore. Also, what is striking is that like over 100 is not anymore licensed. So either they retire or then they move to other positions. So the production must be much higher. On the right, you can see the medication deliveries. You can see that in 2020 and 21, due to COVID, there was less infections, which is quite clear. And as the nurses prescribe only an appointments and meet the people, so also with chronic diseases, the prescribing was much less. But what happened now in last year, 2020, there is a huge shift. Previously, 60% of the medications were for acute infections, but now it is so that it's only 40%. So the shift to chronic conditions and prescribing for chronic diseases has increased after the COVID time. So there is a shift in the work of nurse prescribers. So next slide, please. So the team model was introduced more wide as a part of the healthcare reform now, like 2 years ago. They were starting projects and we started to hear alarming messages from the nurses in nurse prescriber education that the nurse prescribers were omitted, they were forgotten. So the new team model didn't in the beginning take into the account at all that there was this specially educated nurses with different set of competencies and skills. And now there are one study already done and there is starting this shift. So what should be done in order to improve now this team model implementation and not to put the nurses like to work as normal nurses, the nurse prescribers? So what do we know? What are the solutions there? So to differentiate the scope of practice, the job description. So you have to, when starting the team model implementation, describe extremely clearly. So what's the role and what should the nurse prescriber do? Then what is extremely important is to notice that the clinical assessment skills of nurse prescribers are much wider and the differential diagnostics that they can do. So when the patient encounters nurse prescriber, they can be guided to the correct person with correct skills in the team. So to use better the clinical assessment skills of the nurse prescriber. What is also a successful factor in the multiple professional team is that the patient guidance should be, so to whom each patient goes should be very well designed. Lapio Rapi PhD thesis has shown that if the workload of a nurse prescriber is very big with those patients that they can prescribe for. So then it is more efficient use of that role. And then the productivity of the work increases. Also, what is notable is that in the primary healthcare team model, the nurse prescribers improve the care continuity, as nurse prescribers have to always meet the person and assess at an appointment. So they need also the care plan and the treatment plan, and that documentation improves. So all this way, the care of the patient comes much more improved in the team model. So these 4 issues we have found that can make the primary healthcare multidisciplinary team more efficient than what was the situation. So thank you.
Johanna, thank you so much. And I think this is an ample example, of how skill mix is actually aligning with the model of care with a very strong primary care orientation, and also taken into account that sometimes remote and underserved area can be helped, access can be improved if you have this sort of model, if you have a team where you have more flexibility, where you have nurses taking on roles which would traditionally be done actually by doctors. I think that's really great. And I guess we get a little bit of hints from you also about the political noises around all this, because Claudia was saying in the beginning it's disruptive, and I think it's disruptive in many ways, and the empire strikes always back from time to time. Thank you so much, Johanna. And I would like now to invite my colleague Juliane. Juliane, please fill us in. The floor is all yours.
Thank you, Matthias. So I'm going to talk about new roles in the area of empowerment of patients and caregivers that are working more in the community areas and less in the health professional settings as such. So I'm talking about peer educators, mainly in mental health, and also patient navigators. So when we talk about peer educators, these are former patients which have a lived experience of a mental health care issue, and they are providing support to patients but also caregivers to improve their autonomy, improve health literacy, self-efficacy, and self-management, that patients are enabled to get out of their mental health crisis and situation. And I'm just picking out 2 country examples. The peer educators in mental health has been implemented in many countries across the world. But for example, France has implemented this new professional role of the médiateur de santé pair, the peer health mediator, since 2011, and has placed them, those with their own experience in psychiatric services that have recovered. They have placed them in teams in psychiatric services and day centers, and they accompany patients and help them in conversations, face-to-face interviews, home visits, education sessions, to get out and to have a life plan and to get out of this and to help them get out of this situation. And they have implemented since 2018 a training of 8 weeks. And these peer educators are, since the beginning of their training, are employed in these different service settings and provide and are integrated in the teams. I think this is very important. And evaluations have shown a positive impact on the recovery and empowerment of patients when they have been accompanied by these peer educators. And also in Sweden, this is less formalized as a training and as a role in itself, but they have also started now to set up peer support workers in mental health care who provide reliable information about sensitive life issues and then identify a solution together with the patients. And they really convey a psychosocial perspective and complement the biomedical perspective of health professionals. I think this is very important. And secondly, as mentioned before, I would like to give a short overview of patient navigators that can be lay persons, but also health professionals per se. and they have a similar role in regarding to identify needs and to navigate the patients in the health system, to identify barriers, provide education, linking the patient to different providers, and also to other activities that help them to get across and get along with their disease. And patient navigators are usually active in cancer care, disease screening, chronic care, but also target vulnerable and disadvantaged patients. I will just give one example where patient navigators are active in transitional care, and there the German example of patient navigators in heart disease prevention, the cardiologists, is one example of where patient navigators with a medical education background of 2 years, and they provide assistance to patients starting from the hospital up to 12 months after the discharge from hospital, once they have been admitted to the hospital for a cardiological for a heart disease issue. So they provide individual counseling on health behavior. They push patients to take up physical activities, but also they take care of all the complex situation that patients face when they are in the transition between hospital and ambulatory care and have to navigate this. So these are, and there has been a very recent evaluation of this program, and this has shown the patient navigators, those who have, the patients that have been accompanied by patient navigators have shown reduced hospital readmission after the first event. The length of hospital stay was reduced, and also obviously the cost of per patient is reduced. Over to you, Matthias.
So much, Juliana. I find this so interesting and also quite telling, because in these skill mix reforms, you know, the health workforce is very much broadened. You know, it's not just the professionals as such, not just doctors, nurses, pharmacists, but it's also the lay people and other professions. And it's co-production. And for us, you know, our health systems are confronted with a lot of multimorbidities, the empowerment, the self-management, the health literacy. I think these are all key issues. And I think they are acknowledged, but probably not enough is done. And here's one avenue, you know, to really introduce more competence in this field. And they are proven models now, which you can follow. Thank you so much, Juliana. And I would like now to ask all speakers to switch on their videos and their microphones. And Erika, over to you. What's been coming through the chat box?
Okay, it's been a very, very busy chat box. Lots of people very interested in downloading materials, which is always a nice thing to hear. But a couple of questions to kick off with. One was someone was asking about any insights people might have on task shifting to community health workers. They were speaking from a more low income setting, but they were concerned that often this task shifting can be done without sufficient training. So what insights would you have around that? And another one is on what information systems need to be in place to allow for safe prescribing by nurses. But also, it could be argued that where you're going to have team working in primary care, also what information, what data sharing needs to be in place to enable that to happen safely. So back to you, Matthias.
Very good questions, I think. You know, Claudia, you want to start? Just pick out the question you feel best suited to respond to, and we will make sure that all the questions are answered somehow.
I think I picked the community health worker one, although I always like the one on nurses as well, but I go for the community health workers. Yes, we identified there is quite some evidence on community health workers and lay workers as well. I mean, the terminology varies quite considerably across countries, but there is evidence showing that if they are adequately trained, they can actually perform a range of tasks. For sure, in terms of education, awareness raising, it's very, very important, this role. And one of the criteria also is that community health workers are employed and embedded in the community. So they know the specifics in the community. They speak the language. They can approach people. So this outreach role, it's very typical for the community health worker role. And I think that is really critical. So when it comes to these tasks, I think this is a very, very good role. When it comes to clinical tasks, one really has to see and differentiate very clearly what are the clinical tasks they can do. And of course, then they require the training for that. And one last point, it's really critical, first of all, to acknowledge the role of these people, to see what is the remuneration for them, because working for free for longer term is has a lot of also critical elements to it, and linking them to the teams, health professional and multi-professional teams is also really critical. So that's for me on the community health workers.
Claudia, is there also sometimes some resistance or some ignorance, when tasks are shifted to community workers and maybe lay people, that they are snubbed maybe by the established profession and not really recognized because they don't have the same training, the same culture?
Yes, that's really an issue as well. So as I said before, it's really critical, first of all, to integrate them into the health professional team. The supervisory role is also really as important as well. So who is in charge of making sure that they are providing high quality care, and but also they are recognized for their role. So there are a number of issues that are related. So it's really, but they can be an important asset to the professional health workforce if it's well implemented.
Thank you so much, Claudia. Johanna, which question you want to pick?
Do you want to guess the safe prescribing? Okay, so in Finland we have extremely well-developed electronical system. So we have only e-prescribing. So every single person is able to see from home, from anywhere, the prescriptions in every pharmacy. The prescriptions are seen by every pharmacist. And so when you have a nurse, so the nurse prescribing is linked to the point where she's having her appointment. So then she has patient records. So again, this is extremely safe because there must be the care plan and everything is documented. The nurse is logging in and sees every single medication the patient is taking. So we are very developed in that sense. So that is ensured. And it's not possible in private where you would not have the patient record.
Johanna, can I ask you back? Do I understand this correctly? The prescribing nurses have access to the patient's medical record?
Yes.
So that is probably really a precondition, for working in teams and for having these roles and for making care integration actually work, isn't it?
Yes. That is the crucial thing, and that was the safety measure that was thought when launching it. Why it is not possible, for example, on an entrepreneur nurse. You are not allowed, if you don't have access to patient records, you're not allowed to prescribe. You have to have the access to the patient record.
And which part of the nursing health workforce has access to the medical record and which not?
So all nurses see the patient record in that sense, but the nurse prescriber has their own authority. So they have the authority to make changes, and there comes a mark when you change the medication and when you write the prescription that it's the nurse. And also actually for safety precautions, there are warnings. So if you are about to prescribe something that you are not authorized, the system even warns you. So there is the list of the medications with the code. So they are also connected. So the patient safety is ensured.
Now, I have to ask you back again because Finland is such an important example here. I also understand that the medical record facilitates teamwork and care integration. That's the case, is it? So that people do the right thing at the right moment.
Yes, and we see each other. So there is the care is transparent, so for everyone. So I can do an electronic consultation with the physician. So if the patient is here at my appointment and I would not be able to prescribe because she's like allergic to the antibiotic, so electronic system through the physician sees that I have written the assessment of the patient, and then the physician confirms the medication there. So everything is like the multidisciplinary work is even that way enforced.
So as a nurse prescriber, if in doubt, you are not left alone, but you can always connect to a colleague. Thank you so much, Johanna. That's very, very great insight. Juliane, which question you want to pick?
Well, I would also pick the community health workers question. And I think it was mostly on the training aspect, and what I could see from the European examples is that these peer educators, or which are also kind of a community health worker, or they have a sound academic training institutions that have set up a training program for these new roles, and I think this is really telling that it's important to have sound training. I mean, community health workers, their training will be probably quite a bit different, but I guess the continuity of training for community health workers is important, and the supervision. And we have seen from country examples from Zambia, for example, that there is high turnover rates of community health workers due to inconsistent payment or management and working hours. So these issues need to be the whole system needs to be right to give the good right incentives, and then of course also basic training, basic education needs to be there. Then that builds up a good group of community health workers. And yeah. And
Juliane, may I ask you, the training for community health workers, I mean, of course, it differs from issue to issue and from case to case, but is it a one-off thing that, like I think you presented on France 8 weeks or on Sweden 5 weeks, or is it something continuous which starts again and then there's some supervision?
I mean, I think it's a first during the first year, it's intensive training, and then they are involved in the hospital setting and ambulatory setting anyway. So they have, I think, regular training sessions, but not as intensive as in the beginning. So they are continuously involved in multi-professional work with specialists. So they increase their knowledge base anyway. So
okay. Yeah. Great, thank you so much, Juliana. Erica, I think we still have time for another quick round for the panelists.
Quick round, some quick fire questions. Okay, so one is, how can we attract the brightest and the best to work in the health sector for multi-professional teams? Because you rely on people who have skills in, for example, information communications technology. Another one is around addressing the tensions between professionals when skill mix changes happen. Is experience, but also anything that came out in the literature that's actually been done to research on that. And here's the hard question: why do physicians find it harder to accept these changes than, for example, nurses and pharmacists who are having their roles advanced? And how can we address systemic barriers to skill mix innovation?
We're coming back to this disruptive theme, actually. Shall we go in reverse order and we start with Juliana?
I take this hard question of why is it physicians who are opposing these changes. Indeed, in many countries we can see this. I mean, just looking at the example from France, I think the feeling by the patient peer educators was that physicians or other professionals, they are afraid of overwhelming them and considering them as already still weak, still patients and who are not yet stable, though they feel these peer educators, they feel recovered and they're fully operational in a sense. But why? Yeah. So why is the physicians? I think it's also the culture of the medical professions, which is kind of the reason for the resistance of this group against innovation, though they are often also a driver for innovation. So it's not it's not only one side.
So we would need to see strategies how we can convince these professions to be drivers and not barriers. Johanna, I mean, you in your country, you mentioned you are doing the prescribing nurses for more than 10 years now, and you have re-reformed them, and now you had a big institutional reform. There's a lot of politics around it. May you also fill us in a little bit on resistance to the idea of prescribing nurses and how to deal with it?
Yeah, we see it still in Finland, so it has not gone away. So I see it a lot about that we must have information, and what was also said, I think in the beginning by Claudia, is the metrics. We need to measure the impact and make it sure that the nurse prescriber is differentiated in the system, so that we can pick up the information and the statistics on the effectiveness of the work. But like for physicians' resistance, we see that those physicians that work side by side with nurse prescribers, none of them objects. Every one of those nurse physicians are in favor of the thing. So when you have the nurse prescriber in your team, you wouldn't give it away. And then we see that if the resistance is about, for example, that the easy work, the easy cases are away. So the physicians also need like easy cases. So they are reluctant to give the easy cases away because of their demandness of their work also. And then one resistance can be that they are afraid that if their salary is based on the amount of prescriptions, so they do in the afternoons prescriptions and they get paid for that. So you should get rid of that kind of like motivators and change them like structurally before introducing these changes.
So it's not only the culture, as Juliane said, but it's also having the right payment mechanisms that avoid these anxieties that you lose salaries if you have prescribing nurses, and if you share some tasks, and if there's overlap in the scope of practice. Thank you so much, Johanna. Claudia.
So I will address the question about how to attract the brightest people, which when it comes to the health workforce really is an issue. And we have seen, I'm also involved in another research project that deals with that. So we actually know what should be changed or what should be done. It relates to, there needs to be adequate payment, that's for sure. But there are much more elements. So first of all, work environment is really important in healthcare. And we know it's shift work. So there are a lot of things that are really demanding the health professionals. But what is important is that people working in healthcare really have the feeling they can get involved, they can contribute, they have a say, they can also influence the changes in terms of work environment. And work environment has really deteriorated, in a number of healthcare settings. For instance, in hospitals, we know it from a number of countries. Staffing is an issue. So these things really should change, that health professionals, yes, I want to go and work in healthcare. And the next generation, new generation of healthcare workers are much more demanding. So it really has to change in that direction as well, to also meet their expectations and their needs.
Yes.
And yeah, finally, oh yes, leadership and role models. So we need much more people who act as role models to move forward in terms of, this is a new role, a new skill mix change. We will implement that, and having the leadership supporting that. Yes. Yes,
and the trust in the leadership will be probably a very key issue. Claudia, now that I have you speaking, can you wrap up with me in 2 or 3 sentences because we're coming to the end of the session?
Yes, okay, so it's going to be hard, but I'll try. So we have seen I've seen that also from the poll, which I think is really, really interesting. It very much mirrors what we found in the study. So the majority said it's high on the policy agenda. It's mostly related to multi-professional teams. So that is really an issue we have to move forward in the future. it's related to nurses taking up new roles, pharmacists, but also others. So it's something that will become more and more critical in the future to address potential and existing workforce shortages. So I think it's more to come in the future. Thank you.
Thank you so much, Claudia. And I think the issue of making multi-professional teams work is, I think, a core issue. And there are many questions around it. And maybe Finland is very advanced, but we know that they not always perform as we would like to see them perform in many, many countries. Lucy, can you put up the final slide? And I just wanted to make a short announcement. We have a couple of webinars over the next coming weeks. One is on access to care, patient journeys through barriers and solutions. And this is part of the European Public Health Week. We have also on health systems performance assessment, a spotlight series, 3 in a row actually. So talking about, how systems better perform, how we have better outcomes, how patient satisfaction is better. So please go to our website, look up our events page and register, and we are looking forward to see you again. So thank you so much and bye-bye.